Welcome, everyone, and good afternoon. I'm going to call to order this meeting of the Health, Environment, and Community Engagement Committee. I'm the committee chair, Councilmember Cam Gordon. I'm joined today by all committee members, Andrew Johnson, Jacob Fry, Elizabeth Glidden, Alondra Cano, and Lisa Bender. We have 7 items on our agenda. The first 4 are consent items. I'll read those, and if any committee member would like to pull one off for discussion or a question, feel free to do so. The first 2 are from the Health Department, and the first is amending a delegation agreement with the Department of Agriculture, Minnesota, relating to food inspections to more clearly define the scope of the agreement, the retention by the state to license manufacturing or distributing activities for certain food establishments. The second item is authorizing execution of a grant agreement with the Mississippi Watershed Management Organization in the amount of $19,200 to hire interns to assist in erosion control and enforcement. The next item from the city coordinator is authorizing acceptance of up to $40,000 and executing an agreement as needed with the U.S. Conference of Mayors for a Garden and Green Space Award for the development of community gardens and green spaces in Minneapolis. And the fourth one is authorizing an amendment to the contract we have with Blue Sky Veterinarian Services in conjunction with the Minnesota Spay and Neuter Assistance Program, MSNAP, extending the current lease for the use of laboratory and parking spaces at Minneapolis Animal Care and Control. And this would be extending it for 1 additional year to March 14, 2015, in order to provide low-cost spay and neutering services. I will move all 4 of those consent items, and I am not seeing any questions, any concerns from anybody. So all those in favor, please say aye.
Aye.
Any opposed? Those motions are approved. Now we move on to our discussion items. We have 3 discussion items. One of them has to do with our greenhouse gas reduction goal, and that will come first. And we'll get a report from Brendan Slaughterback. This is in response to a staff direction that we made earlier when we were discussing our climate action plan. Good afternoon and welcome.
Thank you. Good afternoon, Mr. Chair and committee members. Again, my name is Brendan Slaughterback from the Sustainability Office. I'm the program coordinator. It's my pleasure this afternoon to talk to you about setting a long-term greenhouse gas emissions reduction goal for the city of Minneapolis. If you recall, back in February of this year, this committee directed staff to return no later than today to bring forward a recommendation for adopting a long-term goal to supplement our existing short and medium-term goals. And part of that direction was also to work with our Community Environmental Advisory Commission to review and recommend such a goal. And you should have in your packets and linked on the agenda a letter from SEAC that was adopted last week with their recommendation to the committee on a long-term goal. So they took quite a bit of time in their regular meeting and at their Air and Climate Subcommittee to talk about how to do a long-term goal and what their recommendation might be. Just to set the stage a little bit, the existing goals that the city has adopted for short and medium term are a 15% reduction by 2015 and a 30% reduction by 2025, both from a 2006 baseline. Those are the existing community goals of the city. And we, again, based on the staff direction, we'd like to set a long-term goal, but just to look briefly, some of the discussion we had with SEAC about the science around why we need a long-term goal. I'm not going to read all this to you, but basically on our current trajectory, the latest science from the International Panel on Climate Change, which just released a new report in part this week, says on our current trajectory, global climate change is expected to have really severe impacts on food systems, on public health, and on ecosystems on our current trajectory. But also in that part of that report that says that we can reduce those risks significantly. We can avoid some of the most substantial risks by adopting a different trajectory for our emissions lower than kind of the business as usual scenario. And basically what they say to stay under the safe limit adopted by the international community, which is that 2 °C mark. They're suggesting that globally we need to reduce emissions 40 to 70% by 2050 compared with 2010. So that's kind of a very, very brief take on the state of the international science. There are other reasons why Minneapolis would want to adopt a long-term emissions reduction goal. Adopting such a goal really gives us some latitude in engaging in some of these longer-term planning processes with other units of government like the state legislature, the Public Utilities Commission, maybe Hennepin County. In particular, the Public Utilities Commission will be looking at longer-term decisions that will go beyond our current 2025 goal to look at resource planning. So what will be the mix of energy that Excel's territory will get? And that has a really major impact on our city's emissions footprint. So adopting a longer-term goal for the city really gives us some latitude in those processes. Likewise, there are a number actually of ongoing studies, one commissioned by the legislature, some run by nonprofit groups, a revisit of the state's climate change advisory group process, and all of these are looking at those long-term goals adopted by the state. And so participating in those would be, I think it would be advantageous for us to have such a goal. We did look with SEAC at some of the existing goals, long-term goals that are out there, both in terms of in our state and across the country. The state of Minnesota in 2007 adopted a long-term goal of 80% reduction by 2050 as part of the Next Generation Energy Act. Hennepin County also in 2007 adopted a long-term emissions reduction goal of 80% by 2050. And then across the country, there are almost 40 cities that are looking at some range of long-term greenhouse gas emissions reduction goals and taking action on those. This table just shows you kind of a sample of what some of our peer communities have adopted in terms of long-term goals. And we had some discussions, obviously, with SEAC about what our goals should be, and we think there's some good reasons why 80% makes some sense. It's translating global science to a very small portion of the globe, which is Minneapolis, is kind of difficult, but we do think that an 80% reduction goal is consistent with that international consensus about what it would take to be in that safe range. 80% is also significantly consistent with state and county goals, and I think that does assist us when staff and elected officials and others go out and we participate in these processes that occur at the Public Utilities Commission or other places, that we share the goals of the state and the county in long-term emissions reduction. 80%, I think, is also consistent with some of the language around significant greenhouse gas reduction that was part of the energy vision, which is in the energy pathways study that this committee reviewed recently. And then, of course, it really, a long-term goal, 80% or otherwise, kind of establishes Minneapolis as one of the cities that are really leading the way on addressing global climate change, realizing that cities have a very significant impact globally and that many of the strategies that can be undertaken really can be part of a city's repertoire. So, as you saw in the SEAC letter and in the agenda, our recommendation as staff would be that the city adopt a long-term community greenhouse gas emissions reduction goal of 80% or more below 2006 levels by 2050. We just wanted to note, as we work on these issues over time, I think our goal as staff is to continue to kind of refine our processes for inventorying our emissions. There are certain adopted protocols. We know those aren't perfect. And of course, every time we have discussions with SEAC, we get into a lot of discussion about what exactly is in and what's out. And so we want to make sure we continue to refine our processes and follow the best practices and established science on how we inventory our city emissions. So that concludes my presentation. I'd be happy to stand for any questions.
I see a question here from Councilmember Cano.
Thank you, Mr. Chair. Brendan, thanks for presenting this information. I'm just curious, if you go back to the chart where it talks about all the different cities, and yep, that one. Can you tell me why Seattle would be 100% by 2050 and why there's a group of cities that are trying to do 80? What's kind of the difference, or why are they ahead in their planning, or what's different from them than from us, I guess, in reaching a 100% goal by 2050?
Sure. I think it's not just, I don't think it's just that Seattle is really, really aggressive. They have significant energy for Seattle comes from hydropower. So they basically count their electricity system as carbon neutral for the most part. So they felt that going to 100% was more doable for them, and they're focused a lot of their efforts on the transportation sector, not as much on energy efficiency. And some of these other cities, I think, where buildings represent a majority of the footprint, like Minneapolis and many of these other cities, that they've chosen 80% rather than carbon neutral by 2050.
Okay, well, I mean, I'll just voice what I'm thinking. I wish we were at 100% by 2050. 2050 feels like a long ways away, and I know that these things are challenging, but, you know, my brain does wonder, is there a way to accelerate this, or is there a way that we can try to be more aggressive in trying to meet these goals sooner, faster, without, of course, sacrificing quality and engagement and buy-in, et cetera, et cetera. But I do see that other cities are moving at a similar rate, so I'll just stick with it. Thank you.
Councilmember Johnson.
Thank you, Mr. Chair. I was just a follow-up related to that Seattle question. Do you think, I mean, what's your assessment? Is 100% achievable in that case, or are they setting too aggressive of a goal that isn't achievable? I mean, are they counting on some magic technology to come out and eliminate their carbon footprint completely?
I don't think they're counting on anything extremely revolutionary, but again, the fact that they have this area of emissions kind of covered that we don't, which is the building sector, really means that they can focus their efforts in more limited ways on more limited areas. But you know, there are, I think some of the consensus internationally is there are a lot of technologies that are available now that we can use to do these things, but 80%, 90%, 100%, all of these goals represent a very significant change from our current state in terms of the technology and sort of our energy system. So it's going to require really fundamental changes, whether we pick 80, 90, or even 100. I think all of those are very, very ambitious targets.
Great, thank you.
I did notice in the report that you had looked a little bit of what would a 2.5 reduction per year lead to, and I think you said by 2050 that would actually have been a little above 80%, which of course made me curious of how fast that would lead us to 100 if we followed that trajectory, because I do have some sympathy with my colleagues here, or there's some anxiousness to say, well, if we don't want greenhouse gases, what'll it take to eliminate them altogether, and what would be the soonest we think we could actually get there. Although I'll just say I'm very comfortable with the 80% right now, and I think aligning ourselves with the county and state is a great first step at leading us into this kind of long-term projection. But I do think we have to kind of answer the question of when and how do we get to 100. So when you played out the 2.5, did you ever see it getting down to 0 or 100%?
I guess, Chair Gordon, we didn't take the 2.5% all the way to 0. Technically 2.5% less a year is sort of like getting halfway to home base. You never actually get to 0, but that's sort of a technical issue. But the 2050 is a long way away, and I think some of the work that's actually going on in Minnesota right now, for example, the state has thought about an energy futures study to really look at what might happen if we eliminate fossil fuels from our energy systems as a whole. And some of that work is really going to inform, I think, what may be possible within the city itself. And I think we can certainly revisit, the long-term goal in the future as we understand what technologies and deployments look like. We didn't, as part of this analysis, we didn't really do a really detailed dive into what does it mean to be 80 or 90 or 100. We kind of looked really broadly at what that might mean, and I can just say that it's a really fundamental change. It's very significant changes in energy efficiency and the deployment of carbon-free electricity beyond what we have today or beyond even what's on the books. So it's a significant change.
I appreciate that, and I'll just maybe highlight that too, because you mentioned significant in the staff report a few times, including a significantly decarbonized electricity grid, generating our electricity from 75 to 100% from carbon-free sources. You also talk about reducing vehicle miles traveled or deploying alternatives to internal combustion engine-driven transportation modes. So I think you're trying to say it'll be a significant stretch to get there, and we have a whole lot of work to do. And I think it's important that we recognize that. But I will be happy to move the recommendation. And I'll note that it's the goal is 80% or more. So this isn't saying we don't want to get to 90 or 100 either. So I'll move to adopt a greenhouse gas emissions reduction goal of 80% or more by 2050 below 2006 levels to supplement the city's existing goals for 2015 and 2025. Any discussion on the motion? Any more discussion? All those in favor say aye.
Aye.
Any opposed? That motion carries. Thank you very much.
Thank you.
And now we have our sixth item, which is acceptance of a 3-year federal grant. And this is fairly significant. We thought it might be worth some discussion because it's not often we get grants this large. This is a grant in the amount of $871,448 to study the benefits of father advocates providing services for expectant and new fathers. So we thought it would be good to hear a little bit more information about this exciting opportunity. Welcome.
Mr. Chair, council members, this is an exciting opportunity for us. I want to recognize my co-investigators on this grant project, Charlene Muzeka and Rebecca Fisher. And I also want to give a special thanks to our CDC fellow, Nancy Andrade, who was conducting a male health needs assessment for us over the past 2 years. And although as a federal employee, she was not permitted to participate in writing our grant proposal, she did a lot of the background work talking to fathers, pregnant women, and the men who serve men in various service agencies to really help us shape our ideas. So it was really a team project to put together this proposal.
Make sure to introduce yourself as well, Ms. Harrison.
Yes, I reminded my staff to do that and forgot. My name is Pat Harrison. I'm the Director of Research and Evaluation for the Health Department.
Thank you.
So this is one of 4 projects that was funded by the federal agency, Health Resources and Services Administration. In the past, when we have looked at who received funding, it's typically unique, the elite universities across the country. So it's really a tribute to the kind of work that goes on in Minneapolis that we were considered for this award. We have 2 major partners in what we'll be doing that will be delivering an intervention to fathers. That's the key partner is the Family Partnership, and Minnesota Visiting Nurse Agency will be involved in the recruiting of the participants. What we really wanted to do is to have some services targeted to men who are expecting a child. talking to them over the past 3 and 4 years, what they say repeatedly is the whole system is designed for women. The health system, the service delivery system is really designed for women and moms. And although they'd very much like to be involved, they're very uncomfortable in a lot of the settings. People don't often talk to them. They're sitting to the side and all the conversations are with mom. And so when we talked to them, they were really quite vulnerable and vocal about their needs. They very much want to be good fathers, and they see this as a life-changing experience. So even if they're not quite on the pathway they want to be, they see this as the optimal time to think about getting a better education or better jobs so they can support their families and dealing with any particular issues they have. They identify their number one health issue as mental health. They are really aware of the stress that they cope with in the communities, particularly families that are living in poverty. Some of them live in violent communities and have grown up in violent families. They are aware when they're depressed and anxious, and they're aware that, like other people, they often don't choose the healthiest options to cope with that. So they may be using alcohol, drugs, smoking, and some behaviors that they'd like to change before they become dads. So that's what this project is all about, is to allow a dad to get 3 things. The first thing would be he would receive a psychosocial screening by a man that he can relate to, somebody that's from the community, hopefully is a dad and really knows what men in these situations are experiencing. So if that screening identifies anything like a mental health problem, a substance abuse problem, or perhaps somebody who needs help dealing with anger management issues in their relationship, they can be referred to resources that are really appropriate for their needs, and be sure to follow them up and make sure they make those connections. They also want a lot of information. They don't really know how to cope with a moody woman during pregnancy. They think they're doing their best, and they actually feel like, well, maybe I'm making things worse. So who can tell me the best ways to respond to a woman when she's going through a tough time? And they'd really like very practical advice about that, and also how to cope with a crying baby, how to change diapers. How do you do all that stuff? What we often take for granted in many of our lives is role models that showed us how to do that. And what these men really speak about is the lack of fathers in their own lifetime, the lack of other males to show them how to be dads. So they really want that mentoring relationship. And we believe that the father advocates, the intervention provided by this grant, will provide a way to test that out. The last thing is just for the father advocates to provide the emotional support to dad, the same kind of emotional support, that mom often gets from her healthcare provider or her visiting nurse. A private place where he can share his own anxieties, maybe things he's uncomfortable talking to his partner about, but he wants to talk to another man about and find out. He wants to find out if this is typical for dads and what he can do. So this father advocate can serve all those roles, providing concrete information, emotional support, and then really seeing him through the journey. So he'll be available during pregnancy and all the way up to 6 months after the baby is born. He can contact the father advocate in any way that those two agree on. It's meant to be a real flexible intervention designed to serve the dads. The moms will be recruited first through the home visiting, and the dads will not be eligible unless the mother wants her partner involved. So she consents first, and then she will give us contact information for the man she identifies as the father, and then we will contact him. And then if they both agree, she will continue to get care as usual, and the men will be randomized. Either they'll get care as usual, which means they can attend the home visits that mom gets, go to the prenatal care appointments and do everything, but nothing really targeted especially for dad. The dads in the intervention will get all of that, and then the special opportunity to meet frequently with a father advocate and design their own care plan and move forward. Both groups, whether they're in the control group or the intervention, will be interviewed 4 times when they start, about 2 months before the baby's born, about 2 weeks before the baby's born, about 2 months after the birth, and then 6 months down the road. And we'll be asking mom and dad really similar questions on changes in behavior, smoking, drinking, drug use, stress management, compliance with recommendations regarding the baby's care and the mom's care, and how they feel supported, how dad feels supported by the father advocate, and how mom feels supported by the father. And the hope is, with the studies, that will show that the fathers that get the more intensive intervention do better themselves, make the changes that they want to make, and that the mothers feel more supported, and as a result, they have lower levels of depression and anxiety and substance use as time moves forward. They will be compensated for participation, whether they're in the intervention or the control group. Both mothers and fathers will get $50 for each of the 4 interviews they complete. So that's the summary of the project, and I would be happy to answer any questions.
So I have one question to start with. How many families or fathers will this provide that extra enhanced service for?
We've estimated that we will enroll 132 pairs, and half of those, 66, will get the intensive intervention.
Very good. It would be interesting to do a little bit lengthy follow-up study too, and even evaluate the children's well-being somehow, but I realize there's limits to that.
But we never rule those things out.
Yeah,
You know,
yeah.
what we can always do in a study like this is ask the parents at the end if they would consent for us to contact them and enroll them in a study down the road, and then if we can get the funding for that and have a way to do that. Because I agree with you, I think that would be an excellent way to look long-term.
Maybe even find another partner like a university or a research institution. Councilmember Fry has a question or comment.
Thank you, Chair Gordon. I think this is really impressive. It's a great program. During a lot of my pro bono work as an attorney, and specifically after the North Minneapolis tornado, one of the characteristics that I was seeing was that you had a whole lot of very, very strong women, and you had a lot of uninvolved and at times confused fathers. So, you know, my initial approach, and perhaps this wasn't the proper approach, was essentially be like, come on, get with it, man. But I think this was really the right answer here. And I guess the only question I have is, how then do you target the fathers that are really in need of these services and delineate them from perhaps the ones that don't need them as much?
Thank you, Mr. Chair. Councilmember Fry. The women that are eligible for this intensive home visiting are typically low-income women, so it's already a select pool. Many of the families will live on the north side or in the central area of Minneapolis. So we think that just as a result of that, we will get some of the highest risk fathers. And we can also recruit couples that we think would be eligible for home visiting and do more community outreach to be sure they even know that this home visiting program is available to low-income families, and then we would have a richer pool from which to recruit the fathers.
Thank you.
Thank you, Mr. Chair. First of all, thank you for putting this project together and for launching a successful effort to get so much support for this area. This past Saturday, I was at a Centro de Trabajadores Unidos por la Lucha meeting on Raise the Wage. And so we were talking to a lot of the women and men whose wages get robbed by companies who don't want to pay immigrant folks. And it came out during that meeting that, some of the immigrant dads are actually facing a lot of the similar challenges that you're talking about in terms of not being able to figure out how to provide for their families and how that impacts their identity, their self-esteem, and sort of the whole family structure when folks are often kicked out of jobs, run out of jobs, or their income is taken away because they simply don't have the proper work authorization. So I can see how this relates to a lot of different communities and can connect to not only expecting fathers, but also fathers who already have kids here in the system and are in a new country and trying to figure out how to be a provider for the family, and not only monetarily, but also also emotionally, physically being present and being able to be with their children. And of course, parents who have to work 2 or 3 jobs to make ends meet because the minimum wage is so low, don't get the opportunity to be with their kids that much. So from that sense, my question is more about what are the racial demographics that this grant would serve, and what are the culturally specific strategies that you're pursuing to engage with communities of color around the parenting and family piece, which could look a lot different than a mainstream family in the U.S.?
Mr. Chair,
Harrison.
Councilmember Cano, thank you. Those are the kind of observations that are so important to us, and we think across all our program, try to take that into account. There were limitations to what we could do with this amount of money, and then even when they gave us the awards, they did a 10% across the board cut, so we have to do the same project we proposed with less money. One of them did limit enrolling people who don't speak English, because it was more than just the matter of getting interviews translated for them. There's the whole question of whether some of the interviews we have are even culturally appropriate for different groups. So the demographic restrictions will be that both mother and father have to be 18 years of age or older, and both need to be able to understand and speak English. But given that, the enrollment, again, can be people from any culture that is receiving home visiting. And I think so the strategies begin long before we select them to invite them to the research project. They really are about getting all families that are eligible enrolled in these intensive home visiting programs. And there are a lot of community agencies that are working that to accomplish just that. The feet are on the ground, but I think it's kind of a never-ending struggle to make sure we continue to reach out to families. And one of the things that we know that is the most effective at doing that is to work with the people that have had successful experiences, and they become then the ambassadors within their own communities to encourage people that this is a safe place. These are responsive people. And with the Healthy Start grant that is pending a June 1st award, there's a community action network component that's been expanded from previous years, and a lot of that is going to be thinking of how to work with community health workers and other people that really know their communities from the inside out and build these trusting relationships with agencies.
Do you expect to hire any staff, city staff, with these dollars?
There will be one city position, and that will be the research assistant. And we would very much like to hire somebody from the community. We did that with our Seen on the Streets grants about male reproductive health. She stayed with us for 3 years and was magnificent. She conducted over 750 interviews. So we will aggressively be recruiting from the community to fill that position. The father advocates will be hired by the family partnership, so there'll be 1 in the first year and 2 in the second and third years. And so they too, I think, are very experienced at finding the right people who understand the needs of the people in their own communities.
Wonderful. Well, I would just like to offer the Ninth Ward office as a resource as you develop and roll out this project, because we are connected to a lot of the Latino community members and organizations that would have a population that would benefit from this. Naturally, there's a lot of Latino folks that speak English very well. A lot of the kids who are born here are bilingual, some of those students and, as you mentioned, 18-year-old plus, some of those young people are parents today, or they're getting ready to be parents. So we'd be happy to connect you to El Colegio Charter School and Clues and some of these other groups that have been kind of around, including Spanish language media, that can kind of reach out to different populations to ensure that, that as many people as possible can be a part of your project. So thank you.
Mr. Chair, Council Member, thank you. That's a generous offer, and you may be hearing from us. Thank you very much.
Okay, I don't see any other questions or comments, so thank you very much for the presentation. And I will move that we authorize acceptance of this revenue for the 3-year federal grant to study the benefits of father advocates, and we'll also refer this to the Ways and Means Committee. Any discussion on the motion? Seeing none, all those in favor say aye. Aye. Any opposed? Thank you very much, and I really appreciate that. I believe I might be the only father, and nobody has to, answer this if I'm not trying to raise any questions, but on the committee, and I really, it's great to see this coming forward, and I can speak from experience. Sometimes you can use all the help you can get making that transition. But it's one of the greatest transitions ever. So I wish at least two of my colleagues the opportunity to be for fatherhood in the future. Now we have one last item on our agenda, and that is our annual report from our Public Health Emergency Preparedness. And this is a opportunity for us to act as the City Health Commission, and this is a lot of information I think we're going to get, and welcome very much, Ms. Blixt.
Mr. Chairman, council members, I'm Pam Blixt. I'm the preparedness manager for the health department, and so part of what I'm going to be doing today is talking a little bit about what the health department does in terms of emergency preparedness. And so consider this partially an orientation, but also we're required to do, as part of the federal money that we get for this work, to do a report to our body, overseeing body, and so you guys are the first step in that process. And so I'm going to start with introducing the preparedness team for the health department, so you have a sense of who's out there working to do this work. So the first person is to my right, Tony Hauser, who's trying to get the PowerPoint cranked up. Tony is the other full-time person that works for the city in health preparedness. And so the two of us are the primary people. In addition, we have Janet Mangelko, who is not with us today. She has been for the last 5 years working doing community outreach and preparedness, and working primarily in the community to build resiliency. And unfortunately, due to the decrease in federal funding, her position's been eliminated, and so she will be leaving us at the end of April. In addition, we are lucky to have Anthony Nixon, and he is here with us in the department for 2 years as a CDC associate. It's a federally funded program to try and promote people into public health, and he is with preparedness for a year, and his year with us will be ending in July, and then he'll be moving into environmental health within our department. So he's staying with the city and with us for at least another year. And then finally, we have Don Moody with us. Don is our part-time associate to help us with all things administrative and IT-like.
Well, thank you, and I'm glad that you're all here, and thank you so much for the service to the city. And I always like to see when we can snag one of those CDC associates and keep them on permanently, or at least more long-term. We've gotten some wonderful people that way.
That would be great, but it's been great that we have so many. We've been really fortunate. Right now, we're the only local health department in the state that actually has these folks. So that is also a tribute, again, just like the program that Pat was talking about, the federal funding. It's another tribute to the work that our department does overall, and, really great stuff to be able to continue to get these CDC folks assigned to us from afar, although Anthony wouldn't say that after spending the winter here. He's from Ohio, but, and he went to school in Atlanta, so it was kind of a shock for him, but
It was a winter.
So part of what I'm going to be doing today is primarily covering what we do and why we do it for public health preparedness. And I'm going to talk a bit about your role as well in that, and talk a little bit about our history in preparedness and how we came to be in this situation that we have a preparedness team within the city of Minneapolis that responds to a variety of emergencies. One of the things that you should be aware of is that within the city of Minneapolis, there are primarily 4 responding departments. And when I say responding, that means that we are actively ready to respond to an emergency. So that would be, as you would think, police, fire, public works as well. And in the last couple of years, they've responded, I think, more than they wanted to. When you think about the water main breaks that have been occurring within the city, they've tended to become more of a response department, I think, than they wanted to be. And then public health is considered also a response department. And with our federal money that we receive, we are required to be able to respond on a 24/7 basis. Although we, aside from those of us that you see here, the rest of our department, really, that's not what they do on a regular basis. And so I'm going to talk about that as a challenge as well. So the entire city council is considered the local board of health and is referred to in statute as the Community Health Board. And so as a Community Health Board, we accept money from the state to be a Community Health Board. And there are 6 responsibilities, areas of responsibility that comes with that money. And one of them is for emergency preparedness. And we're required to prepare for and respond to disasters and assist the community in recovery. And the mandated responsibilities that go along underneath that include, for us, developing and maintaining partnerships. And that's why we've been so engaged in our community work and why it's so critical to us. Another one is to conduct assessments and maintain a capacity to respond to hazards. We're required to train and exercise on a regular basis. We're required to participate in recovery efforts, do surveillance and monitoring, and ensure accurate and timely communications to the community, the media, and our officials. And that would be you, as well as all the other officials within our community so for instance, we have partnerships that we maintain with the park board and our public schools as well. In addition, we have partnerships with all of the other community health boards in the metro area. And so one thing that you may be aware of, or not, is that within Hennepin County, we have 3 other city public health boards. Cities of Bloomington, Edina, and Richfield also act, their city councils also act as their community health boards. In addition, then, the county commissioners are a community health board as well for Hennepin County. And then outside of Hennepin County, it's really all done on a county-wide basis. So a number of years ago, St. Paul and Ramsey County combined to become one community health board. So all of the other ones are together and work as all the county commissioners are the county community health boards. The other thing that you should be aware of is that some time ago, when we started getting the federal money for this, is that we realized we are all required to do a bunch of the same amount of work, and so we started collaborating together. And so we've been working together to reduce redundancy in terms of planning over those number of years. So a public health emergency is an imminent threat or occurrence of threat of exposure to a dangerous condition or a highly toxic agent that poses a threat of substantial harm to people. And we define it in a variety of ways. And historically, I think you might be familiar with a number of the things that may have happened in terms of, in the 1800s, we have the outbreaks of malaria and cholera. In 1918, we had what was called the Spanish flu, and it killed up to 40 million people. In 1976, we had the outbreaks of swine flu and Legionnaires' disease, and we actually continue to have Legionnaire disease outbreaks to today. More locally, in 1995, we had the bacterial meningitis outbreak that resulted in a response of having to vaccinate almost 5,000 people in the Mankato area. And then in this decade, we've had the SARS outbreak that really resulted in almost 800 deaths and expanded to 37 countries within a couple of weeks due to our ability to get on airplanes and transport diseases around. And so most recently, our big concern is about the ability to expand disease on a rapid basis. Some of the things that you should be aware of in terms of these are examples of some public health emergencies, and in some respects, our department would be a lead agency, and in some of them, for example, we would be a lead in response to extreme heat events, such as the one that happened in Chicago about 10 years ago and killed like 700 people. In addition, we would be the lead for a foodborne illness, bioterrorism, or any naturally occurring infectious disease. For other incident types such as radiological or chemical or some sort of natural disaster, we would really just be an assistant and follow the lead of some of the other agencies. But either way, we always need to be able to respond on a 24/7 basis. Public health emergencies can be grouped into three main types. More people die of the immediate, everyday public health threats, but the unpredictable, rare, and catastrophic events often receive more attention. So while you may be familiar with the work of our department in working on obesity or some of the more typical public health threats, we don't really normally see a lot of activity in the news about the great work that we've been doing, but we do see a lot of activity whenever we have some sort of major disaster that goes on. So that's one of the things that we have to be also very cognizant of in terms of being prepared to respond with our communication efforts. Our department, since we've started working in preparedness, has had a series of events that you may not have heard of because they just haven't been big-time news. We've responded almost every year to some sort of outbreak or event, but some of the major things that our entire department has been involved with was the 35W bridge collapse in 2007, where we, the night of the collapse, stood up and activated a family assistance center, and then our entire department was responsible for managing it for the next couple of weeks for the victims that were still waiting for their loved ones to be taken from the river. The next big thing was obviously the H1N1 response that our department was responsible for leading in vaccinating people throughout the city, and that involved every staff member in our department to be able to get up and vaccinate throughout the city. Then in 2011, we responded to the Northside tornado, and the night of the event, we were called upon to stand up a shelter at the Northside Armory, which we ran for a couple of days, and then we activated a disaster assistance center on the north side at Farview Park that we ran for the following week to assist the victims. And then we ran some circulator buses once we closed down the center to make sure that people in the area had access to the resources that they needed. Some of the things that we have responsibility for, we've over time been accumulating both training and stuff, and our responsibility is primarily through the CDC. We are really ultimately responsible for primarily ensuring that we can deliver medical countermeasures that would be vaccinations or medication to the population. But in order to do that, we have to have a lot of other things in place that we partner with both the state and the county on. And I'm going to talk a little bit about that county relationship in a little bit. But also we have been very cognizant of the fact that we can't do this alone, and then we rely on the community, and we work with a lot of our community partners to ensure that there is some resiliency out there, and that once we have a disaster in place, that the community is also able to respond, and they are a critical component of our ability to actually meet the needs of the people. We have in our department a depth of trained staff and a number of people who've been participating in the variety of responses that you've seen, and I think you need to be very cognizant of the fact that it isn't something that they do on a regular basis, and they weren't typically hired to be emergency response personnel. And yet they have taken it on, and they've been willing to step up to the plate, and I'm incredibly proud of the staff of our department for doing that. We have a number of supplies. We have Go Kits available to us that are down the hall from our office that we can pick up and grab and go and get out in the field to be able to set up our dispensing sites or our assistance centers wherever needed. We have a warehouse of supplies in North Minneapolis that we stocked up when we had the flu, so we have a huge amount of personal protective equipment available. And then we have the Strategic National Stockpile. In the event of a large-scale emergency, we may run out of supplies. And the Center for Disease Control and Prevention has created the Strategic National Stockpile, or the SNS, which is a collection of materials that would likely be needed to mount an effective response to a public health emergency. It is a national repository of antibiotics, chemical antidotes, bandages, life support medications, medical equipment, and other medical and surgical items that are available to any public health department in the United States in the event of emergency. The stockpiles are stored strategically throughout the country and can be delivered anywhere in the continental United States within 12 hours. Usually they promise less than 12 hours. It has been deployed a number of times, including to New York City in the response to 9/11 and Superstorm Sandy, and also to the Gulf Coast in the aftermath of Hurricane Katrina. If we receive an SNS shipment, it's up to our department to manage the resource and distribute the supplies to the community. As I have talked before, we have a large number of community partnerships that we rely on and that we have cultivated over the years, and we really have a huge list. We actually have a list of 500 organizations that we communicate with on a regular basis, and we will continue to maintain our relationship with these organizations because we view them as so critical in our response. So I just wanted you to have a sense of that and know that as I'm sure you have a pretty good idea that for yourself, if there was a huge event in your neighborhood, the police and the fire may not necessarily be the first ones to get to your house, but your neighbors may, or some of your community organizations may be the ones who actually are the ones who are able to provide help to you. And so that's why these organizations and many others are so critical to the response that we can provide when we have a disaster, and we need to continue to maintain those relationships. I want to talk about our other major partner, which is Hennepin County. And we contract with them, as we have for many, many years, for infectious disease and control and for some emergency preparedness planning for our disease prevention and control. So they are a huge partner to us, and they are critical, and we have been working with them over the course of years to figure out how we would do a unified command in the event that we actually had to work together on a response. And it's been, it's a little tricky trying to think of merging two units of government together to control a response, but we've been practicing, and I think we have a pretty good plan in place to be able to do so. The chart you see is the chart of our federal funding. My job is federally funded, as is Tony's job and Anthony's job and Don's job. We're all federally funded here. And so the city and the state really aren't the people that are paying for us to do the work that we do. And as you can see, the federally funding has been going down significantly over time, and yet the burdens keep going up. Congress keeps asking for more and more justification to demonstrate that we're actually doing something with the money that they're sending out here into the hinterlands, and so they keep asking us for a lot more paperwork and reports. So this is a little bit about what we've been doing this past year. Just one of the things that we learned as a result of the 35W bridge collapse is that we needed better plans in place and more training to be able to do assistance centers. And so we've been working for the last number of years. We've done a number of drills and exercises. A year ago we did one on reunification, and so we finally have come up with another template for both assistance centers and reunification that we are sharing with all of our regional partners, and getting that information out so that everybody else can learn from our experiences. Then we also have been working to develop more thoroughly what we learned as a result of our experience with the tornado, is that we needed to have better plans in place for the use of volunteers. And so actually that's Anthony's project that he's working on, is to help us more solidify how we would better utilize and have in place access to volunteers when we needed them that would be credentialed and trained and ready to go, which is more challenging than you can imagine. And then we have been working to come up with plans to, as a result of the water main break, to kind of better have plans in place so that we would work with more closely with Public Works and to be able to get information out to the public in a more timely manner about whether or not they need to boil water or whether to use the water, those types of things. So we've been coordinating efforts about that as well.
And we call that program Operation Water Woes?
Yep.
Okay.
Yeah, we just
wanted
did. Yeah,
someone
there
to say
was
that.
actually just a full an exercise this past week that was called Operation Water Woes, and it was a regional exercise with all of the hospitals that had contaminated water. And so it was really to talk through how would we message information about bad water.
Okay.
Upcoming, as you probably are aware, we have the All-Star game coming up in July, and so we are coordinating the medical and health planning for getting ready for that event with our partners from the hospital and medical community, as well as Hennepin County. In August, we have another exercise that actually is being managed and run primarily by the Coast Guard, and it is a radiological event dealing with a dirty bomb explosion somewhere on the river in Minneapolis. So you'll probably hear about that more from police and fire, but there will be a tabletop that we will be participating in, looking at more of the long-term effects from a radiological type of event, for which you'd imagine the health department would have to play a major role in monitoring the long term and checking out, making sure that people weren't contaminated. And then next year we will have a huge regional exercise for mass dispensing of medication, and we'll probably invite you to participate so you can come and learn how we distribute pills. So I will take any questions you may have.
Anyone have any questions? I guess I'll just ask, based on that chart about federal funding, are we anticipating more reductions then? Is that, do we have any idea? Because it looks like it just continues to get less and
It
less.
did, didn't it?
Yep.
Next, it's, what I heard was that this next year may level off,
Okay.
but I think continuing a downward trend, and so I think we need to, we've been talking, I serve on a state work group that looks at funding issues, and I serve on a federal one as well, and everybody's talking about how can we get other, like the state, for example, to start helping to fund some of these programs.
Well, thank you very much. I don't see other comments or questions, but I
Okay,
really
thank you.
appreciate you being here. We appreciate getting that report. I think that and the Health Department's grant that was accepted really does show that our department is doing
I think you
great
do
and
need to
fantastic
receive and
work.
file my report.
Oh, that's true. We'll have to receive and file the report.
I don't want to tell you what to do, but
make sure to do that,
I
too.
do think you do need to do that.
Yep, we will. We will. And I appreciate that. I did just want to, put accolades on the Health Department a little bit, and I'm not, I think Councilmember Bender wanted to mention something too, didn't you?
Thank you, Mr. Chair. As I pulled up the agenda for today, I noticed that our Health Department Commissioner, Gretchen Musicant, has won a leadership award from the University of Minnesota. And I just wanted to congratulate her on behalf of the committee. The school gives the award annually to alumni who serve as visionary leaders, teachers, collaborators, and public health ambassadors in their communities. And recipients must demonstrate intellectual curiosity, critical thinking, and the ability to inspire others. And I think we see that every time your department presents here. So congratulations and thanks for all your great work for the city.
Thank you so much. And I'll move to receive and file that report then. All those in favor? Aye. Any opposed? That motion carries. And I don't think there's any other business for us. I think we've exhausted our agenda. So I will adjourn the meeting. Thank you very much.